after the short break for Easter Monday, here we go again with your 30-minute Monday journeys to the most fascinating thing on earth that it so happens we carry around in our heads, our brains. This is Pospo and BRAINCAST for Multi Learning, and it was only a couple of weeks since we last saw each other. Of course, we were not alone, as we were joined by the unstoppable Dr. Melissa Murray from sunny Florida. We talked about vulnerability and resilience in dementia, but also her own research passion, atypical Alzheimer's. If you missed the episode, you know what to do. Just log into YouTube for the video or Spotify for the audio. This week, we leave Florida and Alzheimer's behind, and we travel down to the country of mountains, chocolates, and jazz. Yes, jazz. Because the truth is that Switzerland is home to one of the most famous jazz festivals in the world, the Montreux Jazz Festival. And sadly, no, we're not going to talk about jazz, but with an equally compelling ambassador of all the good things Switzerland has to offer. She's a professor of child adolescent psychiatry at the University of Geneva that managed to steal her not only from London, where she still holds a position of associate professor at the Great Ormond Street Institute of Child Health, but also from New York, as most recently she was associate professor of psychiatry at the Icahn School of Medicine at Mount Sinai in the States. She's associate editor on top journals in the field, including European Child Adolescent Psychiatry, European Eating Disorder Review, and British Journal of Psychiatry, the Open One. She currently serves as an elected executive board member on the Eating Disorder Research Society, for which she also was a president in 2015. She served on several committees and awards. I mean, to be honest, no, where to start and where to finish. So I think you would agree that she knows one thing or two about eating disorders. So BRAINCAST people, this is Professor Nadia Micali. Prof, welcome to BRAINCAST.
Thank you so much, Pospo, and thank you so much for the kind invitation. And I'm sorry I don't have any chocolate to offer virtually.
So, Prof, a couple of weeks ago, I've invited the clinical team to present a case here at the Maudsley Grand Rounds. Extremely complex case that was reminiscent of the now, you could say, rarely used term of anorexia mirabilis. My dear friend Wikipedia mentions that, in fact, about 2/3 of the holy women officially regarded by the Roman Catholic Church as saints, blessed, venerables, or servants of God, and lived around 1,000 years ago, more than half of these displayed clear signs of anorexia, although they were never diagnosed as such, of course. So, Prof, when was the term eating disorder introduced?
So it's a great observation, Pospo, and thanks very much for making it. And it is true that it is quite likely that anorexia nervosa has been around for a long time. And there are even descriptions possibly of a 20-year-old old Roman girl who also starved herself. So even before the Catholic Church started. But of course, eating disorders as a term was really first introduced in the DSM-3, so in 1980, where eating disorders became a diagnostic category. It is true, however, that the term anorexia nervosa has been around for a little longer, and it was in the second half of the 19th century where anorexia was described at the same time in London by Gall, who was in fact Queen Victoria's physician at Guy's Hospital, and similarly by Lassagne, who was a French Parisian psychiatrist. And then, so anorexia was really the first eating disorder being described. And then bulimia nervosa was introduced and defined in 1979 at the Maudsley Hospital by Gerald Russell, of course. And the kind of most recent eating disorder, binge eating disorder, is really a new introduction into the diagnostic world of eating disorders, and became a diagnosis, or is first mentioned in DSM in 1987, and actually became a full-blown diagnosis in the last version of DSM, DSM-5 in 2013. So,
and I mean, I'm glad you mentioned about the classification, because, if there is one thing that unites all psychiatrists together, is the fact that we all hate our classification system regardless of our subspecialty. The truth is that, most people think of anorexia and bulimia when, they talk about eating disorders. But as you've alluded to already, eating disorders are more than that, right? So can you tell me a bit more about all the other eating disorders that are out there?
Absolutely, and in fact, in the recent DSM-5, and this has kind of been done also in ICD-11, the chapter of eating disorders has even been expanded to be a chapter of feeding and eating disorders. So we now include some other less common possibly disorders and newer disorders. So, of course, we have anorexia nervosa. As you said, it's anorexia and bulimia nervosa, I would say, are the most kind of known in lay terms. We have binge eating disorder, which, as I said, was introduced fully and formally as a diagnosis in DSM-5. And then we have the new kid on the block, which is avoidant and restrictive food intake disorder, a disorder that is characterized by selectivity and avoidant and restrictive eating, as the name says. That used to be a feeding disorder of childhood beforehand, but that's now been expanded to also include adults. And then, of course, we still have the big group of non-specified eating disorders, which include, subthreshold bulimia, subthreshold binge eating disorder, atypical anorexia nervosa, and purging disorder, which is also a relatively new disorder. And we also have two other disorders, which are kind of much less frequent, that are pica and regurgitation disorder. So, they are much less common in reality, but they are also included in the chapter of feeding and eating disorders. So eating disorders are much more than just anorexia and bulimia.
They are. And it does seem that, they're way more common than we may have thought. In a 2019 paper published at the American Journal of Clinical Nutrition, so medical niche notes that the point prevalence of eating disorders increased from 3.5% for the 2000 to 2006 period to 7.8%, so more than double for the 2013 to 2018 period. So, Prof, either we're doing something right, meaning accurately detecting eating disorders, or something totally wrong, meaning overdiagnosing eating disorders. So what do you think?
Again, it's a great question. And we certainly know that overall, I would say the lifetime prevalence of eating disorders is around 10 to 15%, with a point prevalence that is more towards the 5 to 10%. Of course, there are a couple of things to consider when we think of, increases in the prevalence or, big changes and big shifts in similar figures. When we think about incidence or prevalence, we need to think about various things. So one thing to think about is that, of course, as I said, eating disorders are now broader than they used to be. And in fact, DSM-5 came out in 2013, and there were big changes in diagnostic criteria. And particularly, we were kind of tapped on our hands, and actually, a lot of us clinicians really pushed the changes because there was a sense in the field that we were being too strict, basically, and that we were including many patients into the other specified category. And so I think that of course, it was important that we became less restrictive in our diagnostic system. And so, that helps patients, because the more we can diagnose, the more we can treat, and, the better we can support them. Secondly, I think we are certainly better at diagnosing eating disorders. And, as you say, I think we are doing something right. We are better at detecting eating disorders in underrepresented groups, for example, men, ethnic minorities. At the same time, I think we are still probably underdiagnosing eating disorders. And again, we need to kind of do more efforts or make more efforts in clinical settings especially with underrepresented groups.
Yeah. And let's touch on that. It's really interesting you mentioned it because, although any relevant website, you may visit starts with a cliche that, eating disorders, essentially can affect anyone regardless of their background. The truth is that not everyone is equally affected. And this is something you have also highlighted in a few of your papers throughout the years. So can you tell us a bit more, particularly focusing on age, sex, and I know you have some interesting data on sexual orientation too.
Yes, again, it's a great question because, of course, we tend to say that eating disorders are kind of race and gender blind, and it is true because eating disorders do affect boys and men, and they affect people kind of across the ethnicity spectrum. It is also true that they tend that we need to kind of look at various issues. Age of onset is the first, so of course we know that eating disorders and eating disorder behaviors are more common in adolescence. In fact, anorexia and bulimia have a peak of onset that is mostly in adolescence, about 13, 15 for anorexia, maybe slightly later for bulimia. Binge eating disorder seems to have a bimodal peak. It is not quite clear yet because, as I said, because it's the newest eating disorder, research is still continuing, but it seems like binge eating disorder starts also in adolescence, but it can also start in the third or fourth decade of life. And, of course, we also know that females are more affected than males. Of course, there is the question of are we as good at diagnosing eating disorders in males? As we are in diagnosing eating disorders with females? And I always, make the point that our diagnostic classifications and the way we learned and we understood eating disorders initially was through a female lens because the patients we saw were females. And so, our diagnostic criteria are instruments that assess eating disorders are mostly female focused. So, we need to bear that in mind. But it is true that females are more affected than males, and the prevalence is about 3 to 4-fold higher in females as compared to males, at least for anorexia and bulimia. For binge eating disorder, watch this space because it seems that the prevalence is maybe more equal between sexes, but again, still something that needs to be studied a bit more. And in terms of sexual orientation, yes, I think you kind of highlighted our article that came out a few years ago from the ALSPAC study, the children of the 19s, which I have been working a lot with. And it is true that we know the sexual minorities in general, both boys and girls from sexual minorities, are at higher risk for eating disorders and eating disorder behaviors. Both for kind of binge eating type behaviors, but also for kind of weight control behaviors.
And while we keep on calling them eating disorders, and I've read many articles, including statements by the National Eating Disorders Association, saying that eating disorders are rarely even about food. So can you tell me, what does this mean?
Yes, it's maybe difficult to kind of get one's head around it, but it is true that the behaviors when we see a patient or somebody who has a sufferer of eating disorders, what we will see is behaviors that are focused on food. So, for example, eating restriction or overeating or using weight control measures. The behaviors seem to be really focus on food. However, it is true that these behaviors often start as a way of coping with various difficult emotions, difficult experiences, and they often are a way of coping. They provide a sense of kind of feeling in control or being in control, and also kind of regulating those emotions. So in some ways, we know from genetic studies and we've known from phenotype studies for a long time that, for example, anorexia has a lot in common with anxiety disorders and OCD, both at the genetic and phenotypic level. And that, for example, bulimia and binge eating disorder, on the other hand, have a lot in common with emotional dysregulation and emotional regulation type disorders, and with disorders such as ADHD, depression, etc. So you are right that there is a substrate that is not about food, but whereby food in some ways becomes a means of dealing with various things, and it becomes a vicious circle.
Let's try to see then things in a bit more detail. In the 2018 paper, you showed that maternal mental health problems were associated with raised rates of subsequent injuries from preschool to mid-childhood. But most relevant to today's topic, you wrote a whole chapter about the intergenerational effect of eating disordered mothers and their children. Can you tell me more about this?
Mm-hmm. In fact, I wrote my whole PhD on that.
We have 1.5 minutes.
Okay, I will try, and summarize my PhD in 1.5 minutes. No, I'm joking. But one thing that I wanted to say is, of course, that, it has been that the intergenerational transmission has been an interest of mine for a long time. And for that, I have to thank, one of my mentors, Professor Janet Treasure, that I'm sure all your audience will know, but I want to kind of thank her publicly here, because she was the one who suggested that, maybe I could do a PhD on this one day when we were sitting in the old Maudsley canteen. So the reason why I was very interested, and I'm still interested in the topic, is that we know eating disorders have a genetic component. And, whilst beforehand it was thought that women with eating disorders would rarely become mothers, we know that they do become mothers. And we know that eating disorders occur across generations. We see that both in the clinic and kind of in research. And I was kind of very interested in studying the intergenerational transmission. So, throughout the work that I've been doing over the years, we showed that maternal eating disorders kind of lead to high levels of general psychopathology in childhood. That children of moms with eating disorders might show eating difficulties when they are little, and our data also show that they probably have more eating disorders in adolescence. Mm. Of course, the difficulty is that given that eating disorders have both a genetic and an environmental component, it's quite difficult to disentangle them and say, is it genetics or is it environment?
And your team published an excellent paper in the British Journal of Psychiatry, essentially answering the question, how do our childhood eating behaviors affect our eating patterns later in life? Do they?
They do. And we know that eating behaviors have a certain continuity throughout life. And it's also true that in our study that you were mentioning that came out last year in BJ Psych, we showed that childhood eating behaviors, particularly those eating behaviors, and here I'm talking about overeating, undereating, and fussy eating, which were the 3 eating behaviors that we studied. We know that if they were present at a high level and they were persistent throughout the first 10 years of life, they were more likely to be followed by an eating disorder or eating disorder behaviors later on in adolescence. So in the specific, for example, we saw that fussy eating, so children who had fussy eating and undereating persistently throughout the first 10 years of life were more likely to develop anorexia. And this was particularly true for girls. And on the other hand, those children that showed persistent overeating throughout childhood were more likely to develop a binge eating disorder or binge eating behavior. So, we could say that probably there is an extreme phenotype that is already present in childhood, and that is the one that is more likely to persist. Of course, again, the reason might be genetic or environmental, but let's kind of leave that on the side.
And there have been endless studies linking certain personality traits, if you like, with onset, symptomatic expression, but also maintenance of eating disorders. And on that note, I do recall a few years back, Novakovsky talked about the link between alexithymia and eating disorders. And for people not familiar with this beautiful Greek word, it describes the difficulty in identifying and communicating feelings and emotions. So what other psychological traits are common, you think, in people with eating disorders?
So what we see clinically and what the research has showed is that there are certainly some other traits which might predispose for eating disorders. For example, we know that those or individuals who are quite anxious in childhood and have an anxious temperament, but also who are perfectionists, are more likely to develop anorexia later on. So those two traits are usually associated with anorexia. But also that impulsivity and more emotional dysregulation are kind of more common, kind of premorbidly in bulimia and binge eating disorder. And for example, in a paper a few years ago, we showed that those traits characteristic of ADHD, such as impulsivity, were a predictor for binge eating later in life. But it's also true that difficulty in recognizing emotion and also sensitivity to kind of interpersonal or social feedback are a risk factor for more general eating disorders, and that has been shown in longitudinal studies, but also in cross-sectional findings.
Really, really, really interesting. Now, but let's get a bit more clinical, though. So here in the UK, it was only last November that the NHS announced it will scale up the FREED service, and that stands for First Episode Rapid Early Intervention for Eating Disorders, if I remember correctly. So how important is it to intervene early?
Of course, being a child psychiatrist, I'm all for intervening early, and I think as we know in all fields of psychiatry, intervening early should really be one of our main focus. And I'm a great believer in early intervention. And in reality, the literature kind of tells us that intervening early in eating disorders leads to better outcomes, and this is true in adolescence and in adulthood. In adolescence, for example, there is evidence that when adolescents with anorexia are given kind of family-based treatment within the first 3 years of illness, they have a much greater likelihood of recovery. And of course, as you were clearly pointing out, the FREED model, which again allows me to say hello and recognize one of my other kind of longtime mentors, Ulrike Schmidt, who also trained me clinically at the Maudsley. Ulrike was the one who developed the first response rapid early intervention or FREED model, which is really highlighting the need for and the benefit of early intervention, where this particular model kind of is provided for 18 to 25-year-olds who have an illness of less than 3 years. And her many studies which are starting to come out have really showed that there is first an improved access to treatment for patients who go through this care pathway, that patients like and are very satisfied about the care that they receive. And also in a kind of small pilot, she showed that they also have better weight gain 2 years later. So, I think early intervention is really a mainstay of eating disorders. And as it's been done in psychosis, we should really kind of focus a lot on kind of intervening early and decreasing the time of untreated illness.
Because it does seem that, if you don't intervene early, the consequences can be dire. I mean, one thing that the general public may not know is that eating disorders can indeed have a detrimental impact on somebody's body, and in some cases be fatal too. So what are the most common consequences clinicians should be aware of?
So firstly, let me rightly remind everyone that anorexia nervosa is the psychiatric disorder that has the highest mortality across all psychiatric disorders. And only recently in the US has it been surpassed by opiate-related deaths, but only recently and only in the US. Otherwise, anorexia clearly has important physical consequences. And I think it is important to bear in mind that all eating disorders really affect the body and the mind. And I always, whenever I teach trainees, for example, medical trainees, I often say that it is, maybe one of the kind of best areas of psychiatry where you can really kind of treat the body and the mind at the same time, and combine this. And you have to, because you have to be able to treat all the physical complications and consequences as well as the psychiatric side. And so if you think about anorexia nervosa, it's true that in the acute phase of anorexia nervosa, anorexia really affects all organs and all body systems. So the cardiovascular system, hormones, the gastrointestinal tract, bones, etc. And in the long term, certainly osteoporosis and osteopenia are very important consequences, as well as fertility issues. In bulimia nervosa, of course, also there can also be some abnormalities, and particularly in the acute setting, electrolyte disturbances, but also GI problems with, in extreme cases, esophageal tears and bleeding, etc. Binge eating disorder also has some important physical consequences, and because it's often comorbid and overlaps with obesity, all the kind of consequences and physical complications of obesity do occur in binge eating disorder, such as poor glycemic control, type 2 diabetes, etc.
Fascinating, and really horrible consequences, I have to say. Now, Prof, if you had the chance to watch any of the previous braincasts, you would know that we don't shy away from politics. So let's do that. In a 2017 paper where you use this beautiful Danish national birth cohorts, so you studied more than, I can't remember, it was like 37,000 children. So you found that parental young age, low educational level, and overweight or obesity were associated with disordered eating in children. However, your abstract finishes by saying, we found social inequality in disordered eating children. I'm intrigued.
Again, very good question, and thank you very much for that politically incorrect question. Yes, it is. It has been one of my great privileges to work with kind of large cohorts, and the national birth cohort is a cohort that initially started as 100,000 pregnant mothers, and has been followed up. And so, it is a great resource. And yes, as I was saying before, we need to bear in mind that although often the lay view of eating disorder is that they, affect kind of rich white girls, that is not the case. Eating disorders are really class and race blind. And it is important to bear that in mind. We show that in another kind of population-based study on adults that we actually carried out kind of in the 5 South London boroughs, the kind of slum 5 London boroughs, where we show that there were indeed eating disorders in racial minorities. But in particular, focusing on the Danish adolescents, these were Danish adolescents age 11 to 12. And we actually saw that in this kind of young group, disordered eating behaviors, mostly weight control behaviors and binge eating. And by weight control behaviors, I mean, purging to control weight, or fasting to control one's weight. And we found that those behaviors were associated, as you were saying, with parental young age, lower educational level, and parental overweight and obesity. And this was not just explained by binge eating, because binge eating was the most common behavior, but this was also true when we excluded binge eating from our analysis. So also the other disordered eating behaviors were kind of more common in, kind of more deprived population. And I think that's important to bear in mind, because again, we need to be able to detect eating disorders and eating disorder behaviors across the whole population. And, they are there are social inequalities in
and
eating
probably,
disorders.
on a similar note, so what do you think is the, if you like, the contribution of the Western culture of overconsumption and consumerism in the development of eating disorders? So how easy it is to live in a world bombarded, by, several of these type of advertisements?
It's a great question, and it's a complex question. And as everything in psychiatry, we know psychiatric disorders are complex because in reality we have this kind of parallel world in eating disorder where, anorexia nervosa, for example, is puzzling because these are people who are able, in an obesogenic environment, where we are bombarded, as you say, by food everywhere, they are able to kind of keep a low body weight and often kind of resist gaining weight despite, every kind of push from parents, clinicians, etc. At the same time, we know that other eating disorders, such as bulimia and binge eating disorder, have a component or, are more common in westernized cultures. And, again, when I teach, I often kind of remind everyone of the kind of Fiji studies Becker, who showed that, with the introduction of television and kind of social changes or changes in the social structure in Fiji, disordered eating behaviors, bulimic eating behaviors increased in prevalence. So I think it's important that we bear in mind these two phases of eating disorders, but also the fact that, again, genes and environment contribute. And, that possibly in an obesogenic environment, and that's also partly what we've shown in our recent, papers, if you are at higher risk or if you are more prone to have a higher BMI, you might be more susceptible to those messages and, that food culture and all this, that, bombardment of food. And so you're more likely to develop disorders such as bulimia and binge eating disorder.
So since you just mentioned the word BMI, and since we love controversy here, so a lot has been said about the link between obesity prevention and eating disorders, and how people in their attempt to tackle obesity may actually develop an eating disorder. And in a fairly recent paper, a quote, our UK biobank analysis proposed strong positive associations between bulimia nervosa, binge eating disorders, and overweight and waist circumference, suggesting essentially that binge eating shares genomic variants with overweight and obesity. So, controversy time. Is obesity, to some extent, an eating disorder, you think?
Very controversial question. And, there was a push in DSM-5 to make obesity a psychiatric disorder. And thank God, that didn't happen because, I do not think that obesity is a psychiatric disorder. And I think obesity is not an eating disorder. However, I think that there is an overlap. And clearly, there is an overlap between obesity and binge eating disorder and some other eating disorders, such as, atypical anorexia nervosa. People might be obese at the start and then kind of get to a lower BMI, a much lower BMI. And so I think it is always important to think eating disorders when we are kind of treating obesity, because there might be a comorbidity there, and that will affect our treatment and our response to what we do with these individuals. So very important.
We're already run out of time, but I can't help myself and not ask you that question. So final question for the day. We are what we eat, or we eat what we are?
That's the most difficult question you asked me so far. Exactly, and it's the very last. Well, thanks very much for bringing that up. And I have to say it's my own fault for having used, the dichotomy and that, kind of word pun in a paper last year when we were trying to discuss, all the buzz and the hype that's been around on the role of gut microbiome. And, the some evidence in the literature that says, microbiome causes psychiatric disorder. And I have to see that one out, though, because I have to say, I believe in both, and I think there maybe is a little bit of truth in both statements. We are what we eat, and we eat what we are. in the sense that eating disorders and eating disorder behaviors, but all psychiatric disorders, I think, are so complex that there can't be one cause and one kind of effect model, but that there are kind of different pieces that one needs to put together. So, in the sake of complexity, I will sit that one out and not give you an answer.
BRAINCAST people, Professor Nadia Micali, thank you so much for your work, Nadia. And from the lakes and mountains of Switzerland to the lakes and mountains of Canada, as we will be strolling down the busy streets of Toronto, trying to understand how we can use neuroimaging to improve how our brain works. I know, top task for one man, right? And that's why our next speaker leads a team. Now listen to that. He leads a team of over 150 scientists and approximately 600 research staff committed to making discoveries to improve the quality of the life of our patients. Professor Aristotle Voinescos. Until then, Pospo and BRAINCAST for more learning. Over and out.